Advanced abdominal imaging, what the ordering physician should know. For every CT or MRI exam that is ordered, a radiologist reviews the order, determines how the exam should be performed, and communicates this to the technologist via a protocol. Think of the protocol as a prescription for the technologist to follow when scanning the patient. Things that are specified in the protocol include IV contrast, whether or not it should be used, and if so, what type; enteric contrast, whether or not it's going to be used, and if so, the route of administration, as well as the length of time if it's an oral prep, and then the timing of scanning. So after the IV contrast injection is initiated, we tell the technologist when to start acquiring images and also how many times to scan through the patient. Things that influence the technique prescribed include what are the symptoms and what is the clinical concern? What is that patient presenting with? Also, the age of the patient. We want to avoid multi-phase CT scanning in young patients because it results in more radiation exposure. So we factor that in when we're making our choices. And then other patient-related factors, things like renal function and patient allergies if there's an allergy to contrast dye. So let's look at an example. This is part of a multi-phase study, and this CT scan was performed without IV contrast. There's a right renal mass present, but it's inconspicuous because its density is very similar to normal kidney parenchyma. You may not notice that there is even a mass present unless you happen to notice that there's a contour abnormality along the right lower pole. After the unenhanced scan was performed, an IV contrast injection was administered and repeat scanning was performed. And you can see that the kidneys are enhancing brightly. You can also see that there's a right lower pole mass, and the mass is now conspicuous because it's enhancing a little bit less avidly than the normal kidney. So your eye is able to pick up that a mass is present because of the difference in attenuation or density between the mass and the normal kidney. And that renders this mass detectable. The key point is that IV contrast is indicated any time that a mass, a tumor, any kind of lesion is suspected because it increases the sensitivity for detecting these by increasing the difference in attenuation between the suspected pathology and normal structures. So how do you make sure that your patient gets the best exam? Well, the radiologist and the ordering physician both play a role in ensuring that each exam is tailored to the clinical question, resulting in the highest sensitivity test that is possible. So essential information for the radiologist to know in order to select and prescribe the correct protocol includes the enhancement characteristics of normal organs. So after IV contrast is given, each organ in the abdomen is going to take up the contrast, but they do so at different rates and to different peaks. So here's an example of that. These images were obtained every 10 seconds after IV contrast was administered. And they show progressive enhancement of the various abdominal organs. So let's look at the liver first. Notice in these early post-contrast time points, the liver is dark. It slowly increases in density as it takes up the contrast, and it reaches peak at time point G. In contrast, the pancreas enhances more early than the liver, and it reaches its peak enhancement at time point D. So the pancreas is at peak when the liver is still dark, and then once the liver is reaching its peak enhancement, notice that the pancreas is getting darker or starting to wash out. So radiologists need to be aware of how normal organs enhance so that they can time their scans appropriately. The other thing that the radiologist needs to know is the enhancement characteristics of the tumor or the abnormality that is suspected. And what I mean by that is I need to be aware of, does this particular tumor or suspected lesion enhance more or less avidly than the organ that we think it's going to be in? And there are two main enhancement patterns of tumors. The first are hypovascular tumors. They take up contrast, but they don't take up very much and they don't get very bright. And the second are hypervascular tumors. Those take up contrast briskly and they tend to enhance quite avidly. So how is this information used to detect pathology? Well, the goal in any CT or MRI scan is to perform the scan at the time point when the difference in density or signal intensity, if it's an MRI, between normal tissues and the pathologic process is at its maximum. The larger the difference in density or signal intensity between the normal structures and the pathology, the more conspicuous it's going to be and the easier it's going to be to pick up with our eyes. So here's an example of a hypovascular tumor. So again, these are tumors that enhance less avidly than the normal liver. We time the scan for peak hepatic enhancement so that when the liver parenchyma is at its brightest, it's going to contrast with the low attenuation pathology the best. And this is an example of a solitary lung cancer metastasis to the liver, and these are a list of tumor types that are commonly hypovascular. And in contrast, this is an example of a hypervascular tumor. So these tumors enhance early and more avidly than the normal liver, so we start our scanning earlier, well before the liver has reached peak enhancement. So we scan when the liver is still relatively dark and the brightly enhancing tumor is taking up the contrast, as shown here with the yellow arrow. This is an example of focal nodular hyperplasia on an MRI scan. It's a benign tumor that's hypervascular. And here's a list of other types of tumors that are commonly hypervascular. So what does the physician ordering the imaging study need to do? The most important thing you can do is clearly communicate the patient's history in the imaging order itself. And there are three essential components to any history. The first is a sign, symptom, or complaint, what the patient's coming in with, such as fevers, right upper quadrant pain, or nausea or vomiting. Then the relevant past medical history, and include the cancer type if known. And for an example, you wouldn't want to just say pancreatic cancer, you'd want to say pancreatic neuroendocrine tumor or pancreatic adenocarcinoma. You have to include the specific histologic subtype so that we can determine if that's a hypervascular tumor or a hypovascular tumor. And lastly, what you're looking for. Are you doing the scan to look for resectability or response to therapy? Or are you worried about diverticulitis, etc.? So by including these three essential components, it will do two things. One, it will make sure that the technique that's prescribed maximizes the sensitivity of that exam for the patient. And the second, it will help with interpretation as well, because then we can more specifically take our list of differential diagnostic considerations and prioritize them based on the clinical scenario. So what happens when the history is insufficient or worse, inaccurate? Well, in a situation like that, the exam may not be optimized for the patient's situation. So let's look at an example here. This is a CT scan that was performed after IV contrast was given. You can see that there's some contrast in some of the vessels within the liver. The liver's not very bright at this particular time point. And on this phase, it looks like there's no liver masses. However, the type of tumor this patient has is not usually picked up at this particular phase of imaging. We know this phase of imaging is insensitive for the particular subtype of tumor. So this is the same patient, and scanning was performed in two different phases. As noted on the last slide, you can't see the liver metastasis on the image on the left because the timing was off. However, on the image on the right, which was optimized for detection of these lesions, you can see the brightly enhancing metastases are very conspicuous. So really important to make sure we're scanning in the right phase. So the key point here is that a radiologist uses a history given in order to decide how to prescribe the scan, which directly impacts the test sensitivity. So let's end with just an example. Which of the following clinical histories are adequate and will ensure that the correct exam technique is performed? And more than one of these may be correct. So what you're looking for here is a history that provides the specific histologic subtype of cancer that the patient has, as well as information about why that scan is being obtained. So options B, E, and F are examples of excellent histories that provide the information needed to make sure a test is done right. In the case of options B and F, they specify the specific histologic subtype of cancer as well as why the CT is being done. For option E, while it just says colon cancer and it doesn't say adenocarcinoma, it's probably from a practical standpoint sufficient just because so much colon cancer is going to be adenocarcinoma. Certainly if your patient has one of the rarer subtypes of colon cancer, that should be specified. So keep this information in mind in the future as you're ordering advanced abdominal imaging exams for your patients, And together, between you and the radiologist, you'll ensure that your patient is going to get the best possible test.